everybody. Welcome to UIC. Nice. Now it's recording. So welcome everybody to UIC. My name is Alejandro Sanchez, and I'm the second year EP fellow here. So I was asked to maybe give you some cases and give you an idea of one of the stuff we hear today. To be completely honest, we offer a variety of interventions cases, so you will be exposed to multiple different techniques and multiple different clinical scenarios. So I decided to go to some cases that I did over my last month, and hopefully if the time allows, I can give you some multiple quick cases. But let me start with one first case that was an epicardial and endocardial approach for ventricular tachycardia. It was done with, initially the plan was to do RF, only epi, and then alcohol. And then we ended doing alcohol ablation. But to give you some perspective and the clinical correlation, this was a 75-year-old male that he was admitted on CRISE. They offer like advanced heart failure, so they see LVAD patients and transplant patients. So this was kind of an advanced heart failure patient. And they did a right heart cath, and he was on the compensated heart failure, low cardiac index, low cardiac output, and he was already not a candidate or deemed not a candidate for LVAD or transplant. He was a reduced CF. Can you hear me? Yep. Awesome. Okay. And so, well, he was presenting already like months before with monomorphic sustained VTs. And at that time in April, we approached it endocardially. We tried to do our best, and he was free of VTs for 1 month, but well, he recovered. And that was last month. So he had also a history of that he already has a ICD dual chamber implanted. He didn't have criteria for BIV. He has a wide right bundle, but a non-ischemic cardiomyopathy. So that's important. He was labeled to non-ischemic. And also multiple other comorbidities, history of LV thrombus, non-obstructive CAD, pulmonary hypertension, history of DVT-PE, also CKD, sleep apnea, and venous insufficiency. So very complex case. But well, somebody needs to do something. And well, he presented in the setting of acute decompensated heart failure with multiple episodes of sustained VTs in the hospital. So we started doing our epi approach, and in order to do this, we get our vascular abscess in the groins, venous accesses, and one arterial access for hemodynamically monitoring for sure. So I was able to cannulate the CS, and over there, well, I started with a deflectable catheter that's allowed me to pass a stiff wire, then pass a catheter, and I ended doing the perforation of a distal CS branch. This, as you can see, the wire went to the AIV, and then over here, I don't know if this is pointing. Let me see if it's pointing. Here. So over here, I was able to perforate and went to the epicardial space. And then that was technically it was a Maraclebros high-load tip. And over that, I passed a special catheter called the Turnpike catheter, and that's allow us to inflate CO2. That's the silhouette we can see here in the epicardial space. And that's one of the techniques to get an easier, a more easier epicardial access or puncture. As you can see, it's like doing the puncture in a patient that has an effusion, basically. So it's easier than doing what we call a dry tap. So this is the whole technique to get epicardial. And this was our substrate mapping. For this, we were pacing from the RV. So as you can see, there is some areas of low voltage in the basal lateral aspect of the LV. And it wasn't a big surprise to me because, you know, these patients with non-ischemic cardiomyopathies, they tend to present in these forms, like the VTs are coming from this basal lateral aspect, mostly epicardially. And there are other variants that is also basal, but from the medial aspect. So far, we were like, okay, this was an unexpected finding. Other techniques that we use to try to localize the critical isthmus for monomorphic ventricular tachycardia is this one that is called ILAM, or isochronal late activation mapping. And basically, we would like to see a bunch of colors in a small area of the recording. And that basically is suggestive that as slowly conducting critical isthmus is present in that area. But as you can see, this pattern to me was not helpful. I mean, there is something here like red, orange, yellow, gray, but I would have liked to see all the isochrones around, like purple, blue, light blue, green. So not very helpful. So of course, very sick patient. He went into VT, and when you were doing this kind of ablation, ideally, I would like to map on VT because that's where we can see the isthmus or the exits, the entries, and that was the case. And for this VT1, he was able to tolerate the tachycardia decently, so we were able to try to map it. But our problem is like the patient was having multiple different tachycardias. So I'm going to show several activation mappings from different areas of the heart as the tachycardias were allowing it to do. So here we can see like an exit side or early side here in the area where that correlates with the low voltage or the scar tissue that was done in the substrate mapping. And this is like the electrograms. And I'm not showing too much electrograms in this presentation, basically because it was a really boring case in terms of electrograms. We would like to see interesting fractionated mid-diastolic potentials, but this was an HD grid. And as you can see, there was all quiet in the diastole. So it's like not very interesting signals anywhere in the epicardial. So, well, this was the early signal though, but this is like in the CS. I advanced my CS catheter very deep into the AIV, and this was basically during the whole case my earliest recording. So not very exciting on the epi space or in the endo space. This is another island mapping we were able to do, but this is already the endocardial surface of the heart. As we couldn't, as I mentioned, we didn't see anything interesting in the epicardial space. We decided to go for an endocardial approach, and we did it with a transeptal, via a transeptal approach. So here we are mapping a little bit more endo. This is in sustained VT or VT1. And this is kind of the activation mapping as well. And we can see a breakthrough in this area, more like in the anterior aspect and also basal. But we were not able to map the full cycle length of the VT because, well, of course, at some point he was getting unstable. So we have to cardiovert, or he was transitioning to a different tachycardia. But this one was like, if we go with the morphology, like very negative or a QS complex in 1. So that tells us like it's mostly located in the lateral aspect of the wall. It has an inferior axis, like correlates well with this kind of breakthrough that is like in the anterior portion of the heart, and is very positive in V6, V5. So it correlates with what we know that is basal. And we saw a different VTs, similar morphologies but different. And another point that I want to point is that all the tachycardias has this similar configuration when we see these kind of delta waves. And let me see if I can go back to the VT1. This kind of delta wave with what we call the MPR or MDI or maximum deflective index were like very high, like more than 0.56, like in this case, like 0.7. So everything was suggestive of epicardial. And also that's why our initial thought was to go to the epicardial space first. Well, as you can see, we were mapping VT1, VT2, trying to get the earliest activation, again, endocardially. This is an activation mapping. This show basically like we set what we want to record and compare it to our reference. And so basically we were trying to assign time to different areas of the heart and what areas are activated first or what areas are activating later compared to our reference point. And yeah, of course, on all of these VT, as I'm showing you, similar characteristics. Some of them we were able to get more cycle length, in another one less cycle length. But at the end, VT4, VT5, VT6. So at the end, I say, hey, but what if we put everything together, all these different arrhythmias? like try to correlate the early site of activation of all these difference. Because at the end of the day, all the morphologies were kind of similar. And as you can see, we saw 4 of them around this area of the anterior wall, anterolateral wall, basal, and another one a little bit more lateral or inferior. So other thing that we keep in mind is this patient, we did an MRI before getting to our case, and this is what we call a NADAS map. This is done with magnetic resonance. And let me show you the video again. Basically, this area of red is some possible areas of scar tissue, and we are trying to correlate these images with our mapping and trying to figure out where those critical isthmus of VTs are. So yeah, now we have 6 local activation mapping of 6 different arrhythmias. We have this MRI, we have the epicardial breakthrough, and everything, all the information we have so far is pointing us to this direction. So at this time we need to make a decision, like what is going to be our lesion sets or our configuration. So we started by endocardially, first because it was the easiest approach. We were already there. And second, we are less susceptible to damage some structure in the epicardial space. So this is kind of the lesions configuration. Each of these red dots means like a delivery of RF, and it denotates like a drop on impedance for the person that doesn't know exactly what does that mean. So we did some here in the anterior wall, another in the lateral basal wall. So, and of course, we also needed to touch the epicardial space. But regardless, on the top of our head, it was like, okay, we are not seeing any interesting diastolic signal epicardially. We are not seeing any interesting signal endocardially. So we already know we were talking about a transmural or intramural kind of isthmus, which complicate everything much more. But regardless, we were trying to do a sequential ablation, right? They start with the early sites endocardially. So we moved to try to target the early site epicardially. But we know there are important anatomically structured roots there, the phrenic nerve, and most importantly, the coronary arteries. So we call our interventional folks, our friends, they were able to shoot the left-sided system. So as you can see, the HD grid was at this point in the epicardial space. And to me, in my opinion, it was very close to the LAD. Oh, and also I want to mention, like when we are doing this CO2 inflation and then you have a catheter in the epicardial space and you are going to ablate, that's what the next thing we did, we ablate. We are, of course, it's an irrigated catheter and we are infusing saline in the epicardial space. So if we are doing a lot of time, if we are ablating for a long time, this fluid accumulates in the epicardial space. So we also at the same time, we are ablating, but we are also evacuating fluid for the epicardium in order to avoid a tamponade. And to continue the case, this is kind of the configuration of the lesions we perform in the epicardial space. We try to get a little bit away from the early site in this case. Ideally, we will have able to target this area, but as I mentioned, this was very close to the LAD. So we try to do it a little bit more apart of that area. And as I mentioned, the most early signals were in our epicardial, in our CS. So we passed what we call an EP-star catheter, that is a kind of a very thin catheter that can be advanced very distally in the AIV, in the CS system. And just to make the whole story short, we were able to do kind of an entrainment mapping from the tachycardia, and we were able to demonstrate a short TCL PPI with concealed conduction. So that all these technical terms that I mentioned is basically to show or to try to sell the idea that that was the area of interest. So the issue is like, okay, we already target endo, we already target epi. What is left there? And at this point, we are already 6 hours after we start the case. So everybody start to, should we stop? Should we try harder? But well, we decided that, it's kind of a last resort for the patients. So we decided to do another technique that is the alcohol ablation. So with a wire, we were able to kind of find where is this interesting signals and annotate it in our mapping system. This is what I'm marking here. So yes, that's something that is worth to follow or to do. This is kind of the configuration we did. And the important thing is, like, if you are going to ablate with alcohol, that branch of the CS that we are targeting, we should be able, or should we be sure that this alcohol is not going to bleed back, because that's corrosive, right? And you are going to damage another tissues and the rest of the coronary sinus system, which will give you a lot of trouble. So that's why we use like a double balloon technique and an occlusive balloon technique, and we were able to inject the alcohol. That's this picture in the right. This is when we are doing that, like the balloon. And then the distal, we were able to inject the alcohol, and this is like the area we target. So overall, I think we were successful in delivering that alcohol injection. And this is our final set, just to have an idea. Endocardial lesions to the earliest breakthroughs, epicardial close to the earliest breakthrough, but as I mentioned, a little bit distant from the LAD. And this was our branch selected for our alcohol ablation. And it was a successful, I would call it successful ablation to the day. I think that was done over the first week of September. And to the day, the patient remains free of VT. So, yeah. I don't know if somebody has a question about this case or a comment, a concern.
Just want to say terrific case, Alejandro. It's a very complex case, and nice job putting it together.
Thank you. So other things, thank you so much, Dr. Renwala. Yeah, this is another complex case we did. This time was a mitral tachycardia. Just to make the whole story short, so basically it's a third redo. He had already extensive RF ablation, including a posterior wall, the classic PVI, an anterior mitral line. He had a redo in 2024. They retouched the right inferior vein, the posterior wall, and this patient presented with another atypical flutter. And this is the activation mapping, just to see. And we do a lot of this in UIC, a lot of atypical flutter. This case in particularly was done with one mapping system from Abbott that is called ESI, but we also here in the University Hospital, we use the Caro system. That is another mapping system. So you're going to be exposed to different systems. And here we also have a Boston Scientific system that is the Opal, that is available here, and hopefully we can start to do some cases with it anytime soon. But yeah, just to go over the case. So I don't know if somebody wants to give it a try and describe this interesting circuit that we are seeing here. Or I can describe it. So basically, this is an activation mapping. As I mentioned, we are trying to delucidate or put colors to the activation or the sequence of activations. You can see this is the rainbow color. So they start like purple, red, orange, yellow, green, light purple, light blue, blue. So we have the whole cycle length of an arrhythmia in this chamber. So we know east, left atrium. And as you can see here, it's like, okay, it's a mitral flutter. It's going around the mitral annulus. I didn't think so, because first we are bypassing a lot of colors here in this septal border, right? It's not like we have the purple here, it's going up. So when I assess this area here with the grip a little bit more, yeah, and I correlate the history of the patient. This patient already had an anterior line of blood performed for another kind of flutter or another left atrial flutter. And we can see like the signals are separated from each other. There is no continuity in the signal. And also the activation mapping suggests that this is the reentry circuit. It's going through the lateral mitral wall, then going like in the mitral annulus, coming up in the septum, through the roof, and then back again through the appendage, basically. Very cool case. And here, as you are going to experience, Dr. Johnson like to describe these tachycardias like from double loop. So yeah, this is one of the loops, or the the clockwise loop that is going in this direction, anterior wall. I'm not showing the posterior, the same activation mapping from the posterior wall or looking from the posterior wall, but if you do it, you will see the counterclock loop of that tachycardia. So the idea is to find a spot where you can create a line or a lesion or a blade that you can connect both loops, and that's basically how you break these reentry tachycardias. And that's exactly what we did. This is the voltage mapping. We are, instead of volting of trying to correlate timing, this one is basically the voltage in millivolts of the chamber, and we can see there are plenty of scar tissue or low voltage in every area. So very diseased atrium, very advanced arteriopathy, and so it's time to kind of delucidate what is our ablation set is going to be, our lesions. So based on what I described, I think the best approach was to get a line here, right? This anterior line seems to be reconnected. So, and a patient already has a roof and a posterior wall. So why don't connect this? Oh, and by the way, and this is the omnipolar technology. That's something that ESI or the HD grip technology offers, and give you these kind of arrows that is you can do it on unipolar or bipolar modalities, but it gives you a better sense of idea of how the electricity is conducting in this area. This is the same, the propagation. Can get an idea. I think I described it too much already. And yet, so this case was planned to be done with PFA, and we did with PFA. And after delivering a couple of PFA lesions here, we were able to terminate the tachycardia kind of immediately, and then just for reassuring, we decided to reinforce the whole anterior line. I don't know if somebody has another comment, questions that wants to bring up over this case.
Yeah, great case, Alejandro. This is Jeff. Where on this polar map would be like the AV node? Just because you're doing your PFA. I don't know if it's easy to see on there or not.
Yeah, that was actually my concern, but I will say the AV node usually sits more around this area. Can you see my arrow?
Yeah, we can see my
arrow. Yeah, it kind of set in this area, right? The right atrium is around here. The SVC is around here. Is here. Yeah, ideally, I would have liked to map the heat signal, but that's why in my opinion, so far I'm a fellow. I try to follow what my attendees say, but yeah, I like to see more like start laterally here and then going more septal instead of going this way. But that's a great point. That's a great point. And usually when we do RF and we are doing this kind of anterior lines, we like to correlate with where the His is, our His signal, and we can annotate. And if you are doing it with Caro or the Johnson & Johnson system, you have some technology that is called Caro sign, that basically your eyes image, you can kind of, where is my aortic valve and tricuspid junction, that anatomically that's where the compact AV node sits, and you can annotate that location based on eyes in your electroelectromic mapping. Abbott doesn't have that ability, but you kind of have an idea based on anatomy and location. And I don't know if we have time for another case, or should I cut here? I don't know, whatever you guys want me to do.
What do you have? You have one more brief case, Alejandro?
Yeah, I can present quick extraction cases.
Sure.
The main point.
Why don't you present one extraction case? So that'll be a variety then. Go ahead.
Good. So we talk about ablations, but I don't like to forget about devices, and extraction cases are really cool because beside the extraction portion is then after you have to reimplant the devices. So that offers you a lot of opportunities to be hand-on with these devices, implanting, extracting and implanting, and those are really rough cases sometimes. And here in UIC, you have the opportunity to be involved on a lot of them. So this one, we have a 68-year-old male. So he has history of severe MR. He got a mechanical valve replacement that was complicated with complete heart block. So he had a dual chamber pacemaker in 1992. So I'm 33-year-old currently, and I'm from 1991. So these leads were basically my age. So it started to look rough just based on that. So the patient after that was pacing, of course, all the time, complete heart block. He was one of those 40%, 50% of cases that had to progress to pace-induced cardiomyopathy. So in 2003, he get upgraded to a CRT PET system. And of course, what happened with the older RV lead that it was previously implanted in 92? Well, it was abandoned. Thankfully, it was not cut at any point. Nobody was trying to remove that lead at any point. So that offers us advantage in terms of passing stylets and that's a technical aspect for doing ablation. I don't want to extend too much. And then thereafter, of course, he developed like an SVT, SVTs, and he got a defibrillator. So he got another upgrade, and he got a dual coil. And of course, and then years after, he was referred to Christ to Dr. Felix because the device was malfunctioning. He had atrial lead noise that was causing noise reversions, and the ventricular lead also was presenting with a lot of noises, causing a lot of inappropriate inhibition, a lot of pacing. So the plan is like, basically, I think we had to remove everything in these basically 30-year-old leads. I don't think we can selectively, let's take away the ones that are malfunctioning. No, this probably is very tight, all the way from the SVC atrial junction to the axillary vein. Is probably all these leads are probably merged together. So
that area, under that area by the SVC doesn't look so great with the ICD lead. You see how
and dual coil, very tight here.
It's pretty against the free wall of that,
for sure.
The SVC.
And that was one, and that was one of our biggest concern. Like this doesn't look good. This sounds like if we are going to pass a laser sheet or a tie rail or mechanical extraction tool here, it's a very high chance of causing like a tear, and then that's a whole disaster itself. But usually we start these cases passing an Amplatzer, and that's where we pass a bridge balloon. That's a large balloon that we can fast and easily inflate in the SVC in case something something bad happened, like a perforation or a tear of the SVC. So you can inflate that balloon, tamponade at the bleeding, and give time to the surgeons to open the chest and fix whatever is broken. Also, we start putting a temporary quadripolar EP catheter from the groin because we know it's a dependent patient, and we are going to mess with all leads. So that will give us our pacing support during the case. And interestingly, we decided to use lithotripsy or shockwave therapy. This is something that I think is being used recently. Now, it hasn't been described too much, so it's a potential area of research. Of course, the patient has an occlusion, a total CTO occlusion, basically from everywhere. I was not able to pass a wire from below, because ideally I want to pass a wire from the IVC to the right axillary vein to give support to the balloon of the shockwave therapy. But somehow, I don't know to this day, I probably luck, I was able to pass the wire from above. We opened the pocket, we removed the generator, and I was able to pass a wire, of course, with multiple different techniques, like doing soft wires first, glide wires, glide cut, then progressively going for stronger wires, and then we were able to pass our lithotripsy balloon, and we were able to deliver that therapy from all the way from the SVC RA junction to the right axillary vein. So unfortunately, we were so focused on the case that I forget to push the cine pedal, so I didn't record too much those images. I'm sorry about that, but basically, when it was time to do our extraction procedure, we were able to pass locking stylet from basically all 4 leads. No, 3 leads, because the CS lead is something that we didn't want to damage. I was skeptical. I think like we were going to reimplant everything, but at the end we were able to remove the dual coil RV lead, the abandoned the pacing sensing lead, and the right atrial lead. And it was not as difficult as I thought. And I think it was because we were able to give a lot of shockwave therapy. I think that really helped in breaking up all that calcium, all those lead to lead binding, and also freeing this cold from the SVC portion. So very happy with the outcome. The CS, amazingly, the CS lead remained intact. So we reimplanted the RVICD lead and a new right atrial lead, and the patient had a great outcome. So yeah, that's another case, and I don't know if I'm extending already a bit on time, but yeah, very complex cases what we do here. So yeah, that may give you an idea. I don't know if you want me to present another case or we can save it for another day.
Those
We're
are
happy
three
to answer any questions.
Any questions from the panel?
I'm just curious for the atypical flood of tachycardia with the line. Why did you choose pulse field, not just was it a part of like PVI or something?
That's a good question, but basically because I went with the flow of the case. We already have planned to use PFA. We already have our FARA drive sheet there. So yeah, we already opened the catheter. So I went with the flow. But yeah, you can also get it done with RF. Nobody will give you trouble for that.
I think that's a great question. And I think one of the strengths of our program is that we actually really are fellow forward. So if you ask that question in my case, and you have a reason for wanting to pick one modality over another, I'm going to listen to it. And Alejandro can talk offline a little bit about like how fellow forward we are. But I think that's one of the things that we really pride ourselves are. Like if you ask a question like that in one of our cases, why were we choosing this versus that? And you bring up a good point. I think all of us as operators are going to give a good listen to you guys because we kind of look at you as the primary operator in these cases.
Any other questions or comments? Okay, well, these are three really great cases, Alejandro. Thank you very much for presenting. Harry, I wonder, would now be the right time to move on to the case or the presentation of UIC?
Yeah.
Electrophysiology?
So like the general fellows, they can log off, and whatever faculty wants to stay, they could stay for the program overview.
Wonderful. Okay. So I'm going to go ahead and share screen then, if that's okay. And thank you again, Alejandro. That was a really great series of presentations. I think it really shows
Thank you so much.
Breadth and depth of some of the work that we do here.
No problem. Thank you so much for the chance to present.
Can everybody see my welcome screen? Yeah, great. Okay, well, welcome everybody, and thanks again for your interest in our program. My name is Mark McCauley, and I'm the Cardiac Electrophysiology Fellowship Program Director. And on behalf of all the EPs in our program, and I see Dr. Ringwala, our EP Chief, as well as Dr. Johnson, our Associate Program Director, and Dr. Sanders are also here on the call today. We're all very happy to have you here and give you our welcome. So I'm just going to give you a little bit of information about our program, and we'll fill you in on a little bit more details when we see you all tomorrow in the interviews. So just as a baseline, our program has three major sites: UI Health, the Jesse Brown VA, and Advocate Christ Medical Center. Currently, we have two electrophysiology fellows. We have a senior second year and a junior first year fellow. And Alejandro was one of our second year senior fellows that you just heard from. And in addition to these two spots, we'll also be adding a 2+2 fellow this year for a total of 3 EP fellows for this coming year. So again, this 2+2 program is kind of a new program that's onboarding nationwide in certain programs, including ours. And so there will be a total of 3 fellows for this coming year. So at UI Health, there are 2 EP labs, and we have a variety of very new, mapping and ablation tools, including Biosense, Cardo, Abbott, Boston Scientific, Rhythmia. We have a hybrid OR where we do a lot of our extraction cases and complex surgical cases. And we have 6 EP attendings at UI Hospital. Our second site is very close to UI Hospital, is Jesse Brown VA. And we have 1 EP lab with Biosense, also Cardo, and 4 EP attendings. And then Advocate Christ Medical Center, we have a minimum of 2 EP labs with basically every kind of mapping system and software that you could ever hope to have. And we have 3 EP attendings that are employed by Advocate and several private attendings as well. So in terms of clinical activities, we're going to have 1 fellow cover each hospital. We have 3 fellows for this coming year and 3 sites. So basically, you'll rotate at each site per month. And as per ACGME requirements, you'll have a half day a week of continuity clinic. And the continuity clinic will be at different sites as well. The fellows are responsible for supervising the general cardiology fellows who are on the EP rotation, and so play kind of a senior role in education for the service as well. We have way more procedures than you'll be able to do, which is a great thing, I think. At UIC, we do over 500 procedures per year. At the VA, it's 350 plus, and at Advocate Christ, more than 2,200 procedures per year. So a lot of cases, a lot of complex cases, things that will definitely prepare you for clinical practice, whether it's in an academic setting or a private practice setting. In terms of educational activities, we have 3 educational activities per week. On Tuesday, we have an intracardiac electrogram conference with Dr. Ringwala at 7:30 a.m. On Wednesday at noon, we have an EP conference for general cardiology fellows, in which the EP fellows often participate. And then on Thursday morning, we have an EP conference for EP fellows, where we talk about clinical trials, intracardiac electrograms, and surgical approaches. In addition to our clinical activities, we also are very involved in research. So we have clinical projects, translational projects, and we even do quite a bit of basic science projects here too. So Dr. Darbar is an electrophysiologist and is the chief of cardiology here. And so he does a lot of work in genetics and atrial fibrillation. And I also have an NIH-funded lab that evaluates atrial fibrillation and different protein changes that go along with this and how it affects contractility. And then Dr. Avital has developed cryoablation and several other technologies and catheters in this field. So we do a lot of clinical activities. Doctors Ringwala and Sanders and Johnson are also clinically active doing clinical research projects. And we have national clinical trials here, including the RECOVER trial. So there's a lot going on, and all of our faculty are really involved. We also are really proud of our outcomes of our graduates. So many graduates go into academic practice, whether it be kind of a hybrid academic model or a pure academic model. So we have recent graduates, including Dr. Ty Phillips, Dr. Adam Janes, who are now attendings at Advocate Christ Medical Center, which is, as you know, one of our major 3 clinical sites. Dr. James Russell just started at the University of Buffalo in New York, where he's from, and he started an academic practice there. Dr. Patrick Battercher was originally from Switzerland, and so he went back to Basel University. And then Dr. Shim, Kaja, and Yurovich have all been very successful in establishing their practices in very desirable areas in North Carolina, Florida, and Illinois. So a couple words about Chicago. It's a wonderful town. I'm sure many of you have been here either to visit or maybe you've lived here. So just to give you a bit of perspective about where we're located in town. So we're kind of just outside the West Loop. So if you can see the pointer on my screen, JBVA, Jesse Brown VA Hospital, and UI Hospital are basically just across the green from each other. There's kind of like a student center, an area to work, like a workout gym, food court, etc. is kind of between the two. So it's, really, it's truly a medical academic environment. And so two of the sites are very, very close to each other on a very interesting part of town. There's a lot of restaurants and things to do in this part of town too. So it's a kind of a fun area to be in. West Loop area, it's just some examples of different restaurants and different things that are right outside our door. So it's a fun area in town to be in. And then Advocate Christ Medical Center is on the south side of Chicago, and is actually a pretty close drive. It's only, 7 miles maybe, to get from UI to Advocate Christ Hospital. And it's a huge hospital. They do a lot of transplantations, a lot of LVADs, and a very healthy practice. So it's actually relatively close to our two sites up here near the West Loop. And that's it for this part of the presentation. Wanted to see if anybody had any questions, and I will stop the screen share here. I'm sure you'll have more questions maybe tomorrow during the interviews.
Thank you for the presentation today. I had one question is that we have like these three sites. How is the experience, like the fellow experience, like differ between these three sites, like VA compared with the university, compared with the like the third site?
I'll say a little bit, and then I'll open it up for anybody else to chime in. I mean, I think having three sites is a strength because you see different types of practice. So at UI Hospital, you're going to see a very specific type of practice, whereas at the VA, it's a completely different environment. For example, just something very, very simple, like so in terms of SVT, you're going to see more AV node reentry at UI Hospital, whereas atrial tachycardia is very common in people with pulmonary disease that you see at Jesse Brown VA. They have a high volume of extractions at Advocate Christ Medical Center. It's a major referral center across the city for that. So, I mean, you see a wide variety of cases at every site, but every site has their own unique kind of vibe or, kind of flavor of the cases. And I think that you get a real sense of that. I think having three sites gives you the opportunity to really work with a lot of different attendings and see how different people approach similar problems as well.
I'll kind of build on that. So I trained at Loyola, so I thought that there was, in my training, I thought there was a huge strength being at one site. I thought that, having multiple sites would be a potential weakness. Now that I've actually seen how UIC and Price and everything interact in the experience of our fellows, I think it's actually one of our biggest strengths. At UIC and at Jesse Brown, it's largely the same procedural attendings that are doing most of the cases. And we are very fellow forward. The nice thing about UIC and Jesse Brown is that we're not trying to knock out 5 or 6 cases in a day like private practice guys. We're doing 2 or 3 extremely complex cases on extremely sick people. But as you show competence and safety, the fellows become the primary operators. Like Alejandro walks in knowing the patient's upside and down. He comes in saying, I want to do this, this, and this based on their prior experience, and we'll roll with that, and I'll try not to, I tell my fellows that my goal is to like sit in the control room and drink my coffee while they do the whole case, as long as they're doing a good job. And I'm mostly in just giving tips and tricks and talking a little junk while they're doing it. At Christ, on the flip side, they get to go work with, I think it's like 8 or 9 different guys, all the way from our, adjunct faculty who's Ty Phillips, Darshaban, Adam James, that they're much more like us, where they're very academic, very fellow forward, but they're also, doing VAD and transplant patients, so we don't have a UIC. They also get to work with some of the private practice guys that are knocking out 5, 6 cases a day and doing it very efficiently and using all these modalities. And I like to say that when I have fellows, look at your training as accumulating the tools for your toolbox, because when you leave fellowship, you're going to define your own practice with those tools. The advantage we have at UIC and Jesse Brown and at Christ is that you're going to have tools from, about 12 operators. When I trained at Loyola, everybody was trained at Loyola and they all had kind of the same tool set. So you had to kind of pick up stuff on your own as you went. that's something here I think we have a huge advantage, that you get to see so many different perspectives. And we are very emphatically fellow forward at UIC, and the guys at Christ, the adjunct faculty, are absolutely that way too. And I know that I won't be talking to everybody tomorrow, so like if other questions pop up tomorrow, and you wanted to kind of get a feel for other questions that pop up, because we won't be all interviewing everybody, just get Carrie's information and she can always connect you via like email and things like that in case we don't cross paths tomorrow during this thing or if more questions pop up. We want to make sure you guys, I look at it as when we're interviewing fellows that you guys are all potentially future partners of ours. EP is an extremely small world. And it's one of those things that we want to make sure you guys have all your answers, and really at the end of the day, you guys should be looking for fit and for getting the tools that make you successful in your career. So if you have questions about, the way our program works, concerns about fit, or that, you're going to get the tools to do the type of practice you want to do, please ask those. It's a mutual thing where we want you guys to feel at home. We don't want you to feel like you're forced into a spot just to get an EP spot or something like that. We want you guys to feel like this is where you want to be, because we want to train with people that want to be with us. So if there's questions that rise up through this process that you want filled out to have a better feeling for, fit and how it'll fit into your goals as a career, just ask them. This is our time to do it. And it's not constrained to the 25 minutes that we have during the interview. So if stuff pops up, inevitably when you're in front of the camera, you're like trying to look good and come across professional and everything like that. And then you'll be like, oh crap, I forgot to ask this question. Please ask them. We'd rather you get them off your chest, ask us what you want so we can make sure that it's the right scenario for all of us moving forward.
Absolutely. Well, any other questions or concerns? If not, we really look forward to meeting with you tomorrow and getting to know you a little bit better.
All right, guys. Good luck tomorrow.
Yeah.
We're gonna be really rough on you. Lots of questions and stuff. No, just kidding. Totally non-toxic. I met a bunch of you guys recently, so look forward to talking to you guys in our interviews tomorrow. All right, guys.
Thank you.
Bye. Thank you.
Bye-bye.
Recording will be sent out later today, so if you want to review any of it, please feel free. And again, tomorrow, for everybody that's here, you need to just be present on Zoom for your interview times. You'll each have 3 interviews. I think there might be one person out there that has a gap, and I apologize. I try not to have you guys have gaps, but I apologize ahead of time. But you just need to be present on Zoom for your interview times. Thank you for joining us. We'll see you tomorrow. Bye.
Thank you.
Thank you.
Bye, guys. Nice to see you.
Thanks, Alejandro. Appreciate it.